All right. So it's 6:01. My name is Darrell Lewis. I am the technology guy, media manager for Dr. Agarwal, and Dr. Agarwal is actually on his way. So, Carrie, we can go ahead and get started.
Okay, fine. Everybody, we've got the screen up. Tonight, we were just going to talk a little bit about how to actually prep a patient's chart to get ready for the visit that's about to happen, and the steps that we take here in Florida now in order to prepare for that visit. So we're going to talk a little bit about doing the chart review, how to update the problem list, how we pre-screen our appointments, the use of sticky notes or communication devices within the EMR to give the doctor some notes of things that need to happen during that visit. We're also going to talk about, I threw in, there was a recent OIG audit that was just done in September of the inappropriate use of CVAs being coded in the office. And then I actually was going to do a live demonstration in eClinical to show you how to update and add things to the problem list and actually do a pre-screen of the charts. So first thing that happens is typically what you would do is in the morning or the day before, typically the day before, you want to run some type of report and identify any patients or visits the following day that involve documentation of Medicare risk adjustment codes. Typically what we do is we review the chart, all the documents, we gather all of the MRA conditions, verify it against the MRA listing to make sure that they are valid conditions, we have the appropriate ICD-10 code, and that there is a score available for them. We typically track all that information in an Excel spreadsheet so that as time progresses, we don't have to continually go back through the entire chart. We can, at the next visit, only review the chart from where we left off. So we keep that in a spreadsheet, and then we just keep adding on as we review it. We use that spreadsheet. The next step would be to make sure that everything that was found, all the conditions that were found during the chart review, are actually loaded and accurate in the members' problem lists. You want to verify that all the conditions that exist that were found during the review are in the problem list. You want to add any new conditions that were found that need to be added to the problem list. That is done. I'm going to show you how to add some supporting evidence if it is something that we can actually hard code. And then you also want to remove any outdated codes or conditions. And that would be for codes that maybe now have a newer combo code. So if the patient has CAD and angina, you want to remove the old code for just the angina and only leave the combo code for the CAD with angina. You want to remove your acute codes and replace them with history of codes if applicable. So you just want to make sure that that problem list is updated as possible, because that is where you're going to start pulling all of your MRA conditions from. Then we're going to go through this pre-screening process where we actually go in the morning of the appointment, we pull up the shell of the progress note, and we actually then move all of the MRA conditions that need to be assessed that day into the assessment area so that when the provider sees the patient, he has a clear understanding of the conditions that need to be assessed and documented that day. It really helps out, you know, so that they're all captured in one visit, or at least the bulk of them are. You know, the provider is not scurrying around trying to look through problem lists to see what he does need to document, what he doesn't. It's all right there for him. And then, of course, the provider also, if he disagrees with something that's moved in, he also has the opportunity to remove it that day if he believes that it's not a valid condition. and he can do all of that before he actually even signs his note and locks it. But we've actually found that this is a very effective means of making sure that all of our MRA codes are documented and supported in a progress note and submitted. And then once the conditions are done, we don't do the pre-screening for every appointment. We track it. If all the conditions remained in that initial progress note and they were documented and submitted, then we would not be pushing them through for every visit, just the next reporting period. We're also I'm gonna show you how we use mainly in ECW. There's little sticky notes, or usually all EMR systems have a means of communication between the reviewer and the provider without it becoming part of the official medical record. We put some information in there a lot of times. For example, if the patient has COPD and the PFT on file is outdated, I may put a sticky note there, say, please order a PFT, during this visit, or just any other information that I want to communicate with the provider that he needs to know during that visit. Like I said, ECW has what they call a sticky note. Other EMR systems, they typically have a way to do that. If not, I've seen some providers use the chief complaint area, where they would allow me to just put my information in the chief complaint area, and then during the course of the visit, then they remove that and just put either follow-up or the true intent or the chief complaint for the visit. It's just a way of communicating with the provider. So Dr. Agarwal actually wanted me to talk to you about this recent OIG audit findings. I actually put it in one of the handouts, the actual full report. You can go through it. But because we've talked about coding CVAs in the office, which is actually totally inappropriate, it just came to light. I just found this out on the internet that the OIG did do an audit. Their premise of their audit was for Medicare patients coming from traditional Medicare going to an MA plan, but they did pull out 582 members that were selected for the audit. And out of those 582 members, 580 of them, the acute strokes were documented and reported inappropriately, meaning that they were coded and submitted beyond the acute episode, and typically what they found was it was being coded in the office setting. It actually resulted in over $14 million in overpayments to the MAs, that the monies are now being recouped. So I really just want to stress to you that these acute conditions cannot continue to be coded in the office. You're going to find that, number one, obviously you're going to lose scores. Number two, there's inappropriate payments happening, and at some point those payments are going to be recouped. So please, it's just so important that these acute conditions do not continue to be coded. And again, I put the whole report out there. It's like 25 pages. If you'd like to read it, you can. But this audit was done September of 2020, so I just thought that was something I would include. Them when we do a chart review. We track the condition, the code, the evidence where we found it. Typically, we document the last progress note or last office visit that happened when we did the chart review, so that we know we don't have to go back to the beginning of time. We can just review from where we left off. But you can see in this case, we found quite a bit: atherosclerosis of the aorta, chronic pancreatitis, an aneurysm, granuloma. We found CAD with stable angina. There was also CAD with unstable angina, and you can see where I highlighted it in my comments, is that you only use this code when the angina is truly unstable, and your documentation must support acute symptoms. So we're going to use this. I'm going to use this review to start to build the problem list and to correct the existing problem lists that are in there in just a minute. So I did it for a couple of patients. Here's another patient. We have some things. Here's where the patient had a CVA. So that's highlighted, obviously acute condition, removed from the problem list. See correct code I-69-359 for any residual effects. So these are just some notes that I actually, when I do the chart review, I would give to the provider. But I use these again. Here's the next case, quite a few conditions, some feedback to the provider. But again, I use them when we build the problem list. So I wanted to do a little demonstration in eClinical. So using those 3 cases, let me just pull up one. And let's go to test case number 2. So in this patient, I've actually done the chart review. So the first thing I'm going to do is I actually go to their problem list. Let me just put this in alphabetical order. So I go through their problem list and I say, okay, so in here already is hemiparesis, but it's the inappropriate code because this patient actually had a CVA, and they have late effects hemiparesis. So if I'm going through this, I'm going to go ahead and say that I'm going to remove the inappropriate code for the hemiparesis because this one does not reflect that it was late effects of a CVA. So I'm going to go ahead and remove that and add it to the medical history. I'm going to go ahead. I see that they have hypertensive, kidney disease 1 through 4, but I also see that they have CHF. So the appropriate condition would be hypertensive heart failure with kidney disease. So I'm going to remove the inappropriate code. This way that there's no opportunity for somebody to select the wrong code. The pulmonary hypertension we found, the CHF we found. Here's your CVA as acute CVA, totally inappropriate in the office. So I'm going to go ahead and remove that. Here's their late effects of their CVA, their chronic kidney disease. They also have shortness of breath, edema, and then here of CVA without residual effects. So I'm actually going to remove that code because of the fact that this patient has been diagnosed with hemiparesis as a late effect. The history of without residual effects does not apply. So I'm going to go ahead and remove that. So now their problem list is current as the review that I just did today. Next, what I would do is I go in, and here's where you can start to hard code some of the information. So when I did the review, the pulmonary hypertension was found on an echo on 5/20 of this year, and the pressure was 40 to 45. So I hard coded that in the note because so now every time that you pull pulmonary hypertension into your progress note from your problem list, this supporting documentation will always appear. You don't have to write it every time. Here again, the congestive heart failure. There was a hospital report. They were admitted for acute CHF, and they were also seen post-discharge by the cardiologist who also confirmed the diagnosis. So those are the types of things that I would hard code in here, so that each time you use the code, your support already appears in your progress note. And it just lessens the burden on the provider for additional documentation. Here, the CVA, the hemiparesis, I just put status post CVA 2018. So as much information or evidence you have that clearly supports the conditions, you want to try to hard code in here. It just saves the physician a lot of documentation time. So now I've done my chart review. I've cleaned up my problem list. Now I'm going to go to the progress notes. And here's where we do our pre-screening. So this patient has an appointment October 2nd. So I'm going to go ahead down here, and in the assessment area, obviously, you know, everything is blank so far, but as far as pre-screening, I'm going to go ahead and start to move the conditions over that need to be assessed that day. So first I'm going to move over his hypertensive with heart failure and his kidney disease. And I know when I use that I'm required to also document the congestive heart failure. And you see how it brought in my hard-coded note. And I'm also going to pull in my CKD4 because that's also a requirement of the hypertensive code. Here, I would advise in the sticky note to the provider, please document most recent GFR to support the stage of CKD. Because labs are not something that you really want to hard code because they change all the time. So that would be my note to the provider for that day. I also want him to assess the member's late effects of his hemiparesis. And his shortness of breath, his edema, or really more signs and symptoms of a CHF. They're non-MRA. I would not pull them in. But the second note that I would put in here, and let me also tell you that I would date that. Must document support for hemiparesis in the physical exam. So many times I see that condition coded, and when I look in the physical exam of the extremities, everything is normal. So now you have no support. So I would leave the note to make sure that they just document in the physical exam any type of weakness, muscle wasting, that kind of thing that would support the CVA. And then that's how we pre-screen the chart. So then when the patient comes in, the provider sees the note, he knows exactly what conditions he needs to address that day, in addition to any acute things that prompted the visit. And then I would expect to see the current status of each and then the corresponding treatment plan. But that's pretty much how we go through the process of preparing for an MRA office visit. I can show you another example. Let's do test one. Same thing, I've already done the chart review. I'm going to go through here and I'm going to get rid of anything that I can get rid of. So here I have angina at rest. I have angina unspecified. I have CAD without angina. So I'm going to remove that because obviously I have some type of angina that's already been documented. Here is CAD with unstable angina. I'm going to remove that because I like to remove that. And if that clearly is a case of unstable angina, I want the provider to go out and get that code. I just don't want it to be pushed over inappropriately. So now here I see CAD with stable angina. So that would be the combo code and the correct code to use. So I'm now going to remove the simple code of angina. And I'm going to remove this one as well because we now have the new updated combo code. I'm going to leave the old MI. It's inapplicable. It no longer has a score. This patient also has an aneurysm that was found, and they have chronic pancreatitis. The aneurysm, I hard-coded. It was found in a CT of the abdomen, the date of the scan, and the size of the aneurysm. their atherosclerosis. He sees the cardiologist every 3 months, if that's what it is. You know, you can also put that there as well. He also has a diagnosis of uncomplicated alcohol dependence. And so here I put strongly advised to abstain from alcohol in light of chronic pancreatitis. I could also put, you know, numerous places that I saw a reference to the alcohol, how much he was drinking, that kind of thing. But anytime that you have any kind of evidence or anything that you want to always put in your note, you can put it here. You may want to put the amount that he's drinking. But anyway, so now we've cleaned up the list. And then again, we would just go over now to the progress note to pre-screen it. And again, we're putting these in here just to alert the provider that he needs to discuss them and assess them that day. As a coder and the pre-screening process, we only push conditions over that have MRA value. There could be other chronic conditions, but we don't address those. If the provider chooses to that day, then that's fine. But we only take responsibility to make sure that your MRA codes are in there. Oh. I don't know why that one didn't go in. 1 second. Hold on. I don't know why that is, because it's on ICD-9. 1 second, let's see. So you can always add it here as well. Cancel. Okay, so I can't, oh, there you go. However, that's the wrong description. So put that in there. Let me, yes. So I actually want to remove this, and I want to remove it from the problem list because it's the wrong description. It's the right code, but the wrong description. Here is the one that I want to, but for some reason it says ICD-9. So I'm going to remove it. And then I'm going to add the correct ICD-10. And let's see. Let's see one in here with the right. Okay, so here you go here. Here's the correct one. And I would just say unspecified type at this point and add it. And then we can go back into the assessment and push the correct one in here. And let me see why this one didn't. Sometimes it takes a few times to fool with it. Okay. So now the wrong one should come out and the right one should stay. And there you go. And then that's how we do the pre-screening process. Again, it just alerts the provider what they need to address that day. And, you know, the current status and the treatment plan as always. And again, if the provider were to disagree with one of these, he certainly has the option to remove it from the assessment. These are not to say that these are actual, verified conditions. These are just what was found during the chart review. Ultimately, it is always the provider who makes the call. We as coders just tell you what we found and where we found it at. But again, we found this process to be so successful, that everything is documented, everything goes through, and it helps to maintain the provider scores on an even keel basis.
Okay.
So in a nutshell, that's how we do that.
Can you show me in the chart here, the examination and the review of system?
Well, I didn't do one.
Okay. So now what I'm trying to figure out, you already created the assessment and the problem list before the patient came to see us, right? Based
Correct.
on the whole chart. And then
Based on the chart review.
And now then the MA or the physician need to add the examination and the review system and HPI, is that right?
Correct. The provider then at the time of the visit, when the patient presents themselves, they would go through their normal process of documenting the note, and then just it alerts the provider to the fact that along with the other conditions.
So a guy like me, and he told me what to do, but I forgot to do it, then what happens?
So this is Dr. Bensal. So Subodh,
Yes.
the whole idea of the problem list and the MRA scoring is so that you don't forget that. So
Okay.
you
Exactly.
are seeing the patient must address every condition listed in that. So whether it's dormant or what, they should address in history and also address in the examination.
So what I want to learn about the steps. So like you do pre-visit coding, pre-visit preparation of the patient chart for the patient, then the patient come and have a visit. Do we have another audit after the patient is left?
It's not immediately after. Typically, in our world, we do chart reviews probably every 30 to 60 days. So within that 30-day limit, when I go back through all the patients, I will then go to their previous visits to make sure that all the conditions that we put in your progress note remained there. They were documented and reported appropriately. If for some reason some of them were removed, then I would note that say, for example, the chronic pancreatitis, the provider removed and he didn't assess it that day. At the next visit, I would push the chronic pancreatitis back in because that condition still remains undocumented.
Well,
So as you go through the cycles, you eventually get through all the conditions, but the post review doesn't immediately happen like within a day or two of the review. It can if you have that type of staff and manpower, but as coders overseeing an entire MSO, we're more on a 30 to 45 day lag.
So let me ask you, suppose I have 30 patients on the schedule.
Yes.
So how one coder can take care of 30 patients? It need 2 people or 3 people? How many manpower you need?
To review 30 charts for the first time, it would take one coder 1 day.
Okay, 1 day.
But I would not suspect that all 30 of your patients require MRA documentation.
So
maybe if you had 30 patients a day, maybe only 10 or 15 were involved in a MRA or risk environment that required this level of documentation.
And second thing is that it's the first time, but if it's a repeat visit, then
they go fast.
Yeah.
Okay. That's Raj, it's very impressive. So what I'm trying to understand, for a non-MSO physician like Dr. Parikh or Dr. Haber and Dr. Toby Bond, they would like to have their chart just like yours. It's beautiful. It's well done. And so I would like to see how we can learn from you to get into this system, able to put effort in this and still able to, justify the expenses. So how we convince Dr. Haber, Dr. Toby Bond, and Dr. Parikh that let's see the chart at least once or twice a year and able to capture all the MRA, which Kerry is teaching us. So I really invite other people to chip in and tell us. I don't remember talking to any primary care physician who is doing something like this in their practice. I would like to say, if we come on and tell us anybody doing this, what Dr. Bansal doing in his practice.
Well, so there's a difference. There's a difference to both. We do it at MSO level, not at practice level, because our money depends on in the Advantage plan. Every Advantage plan should be doing it. So if you have an Advantage plan patient, whether it's HealthSpring, whether it's Blue Cross Blue Shield, or whether it's Humana, the MSO which has brought that product to you, that MSO's job is to do this for you because they're making money from this, right? So
Yes.
Because primary cares do not have the manpower to do it. So what Kerry is showing here is this level of commitment is only possible when the reimbursement from CMS is dependent on MRA. Now, in the ACO world, we do benefit a little bit, and it may be worth for us to look into it, because if we get 3% or more, so if we make $3 million, $4 million extra just from MRA, it may be worth for us to hire 1 or 2 MRA person to do at least, if not to this level, to some level where we can increase it. So the point is that if you have an Advantage plan patient, you should ask your MSO to provide this kind of service. And if they're not providing it, they're wasting money for themselves and others and not documenting enough for the patient. But from the ACO point of view, we'll discuss with David, with you, with other ACOs, and we will draft a policy of do what to do and how to bring, so that as collectively, we at least cross that line, which requires at least 3% increase in the MRA.
Yeah, that's impressive. Now, that's the right thing to do, to learn the right coding, learn the right property. And basically, they don't teach this in school. So you have to learn this on your own. Or somebody has to teach you, right?
Absolutely. Absolutely.
This is Toby Bond. Can I add a couple things?
Sure.
Sure.
Okay, first of all, when I signed up with an MSO, the first thing they did was audit my chart. And then they came back a week or two later, and it was about 50 or 60 patients. These are MA plans, okay? They handed me a notebook, and the girl went through it with me, and it's the most brilliant coding thing I've ever seen. They had the patient's name and the codes I was missing, okay, on a sheet of paper. Stapled to that piece of paper, the next paper was the ACO, with the atherosclerosis of the aorta, or as the MRI with a report that justified all these codes. So I didn't have the time or expertise to go through and figure this out. They looked through the patient, they copied the notes out of my charts that I already had, and they highlighted with a highlighter and told me what codes to add. And I spent about an afternoon and updated all the codes in the in those 50 or 60, MA patients. Now, Dr. Banzo, when he said he's right. Now I've got 400 or 500 ACO patients, and that's a huge product, but versus 40, 50 to 100. Okay.
Correct.
But that was the most organized thing I've ever seen in my life of coding, of how they made that notebook with the patient's name and the codes that supported it, and copied out of my own chart, MRI of the head, MRI of the neck. And then they added some codes I've never really thought about, and this is low-hanging fruit. You add a code for dependence on opioids, dependence on benzos, and that's a 0.2 or 0.3 kick right there.
Correct.
There's some low-hanging fruit, but to get the difference between the ACO and the MSO makes a lot more money on the risk scoring and the MRA scoring than the ACO.
Correct.
So Dr. Banzel is right. I mean, how much effort do you want to put into ACO until we can make more money out of it?
Yeah. So
So
we just
Toby, let me ask you, how did they get all the info? Did you give them electronic access to your EMR, or they came to your?
Yeah, they did it in Florida. Brought a notebook. I'll show it to you. It's the most brilliant. It's the easiest thing. It showed me where these codes were in my chart. They read the chart, and it just took me a couple hours to add these codes to all of those MA patients. You know, it was probably 50 or 60.
Very nice. Very
You
nice.
know, if you scroll down on eClinical Works on this thing, there's a risk calculator that you can calculate, and I would do it, and I would kick it up 0.3, 0.6. You know, I could have instant gratification as soon as I added those codes and hit the calculator. You know, to add on to eClinical Works, you pay a little something every month. But when you go to the,
Toby, let me ask you.
when you move
Let
from
me
that,
ask you a question, Toby. Let me ask you a question. If the ACO consultant come with a list of the patient with the drop code, you know, the blue sky give you the list. So I'm sure what do you do with that?
well, we get those lists from like United. They give us, you know, they pay me something to fill out a stupid form, and they say these are potential drop codes. Well, almost every patient that's older had a peripheral vascular disease, and I'm thinking, this patient doesn't have a peripheral vascular disease. This patient doesn't have peripheral vascular disease. But when this coder from the MSO went through it, they showed me where it was an ultrasound that showed some vascular disease. You know, there's multiple ways you can get peripheral vascular, but I'd never even thought of it because this person wasn't going to the vascular surgeons getting stents and stuff like that. You know, it's just a finding on a CT or an ultrasound. And so, but once again, those MA patients, United patients, I don't have time to go through the whole chart. So I usually go, you know, I can't check it. But when the MSO came in, they copied the report from my chart, printed it out, and it attached it to the patient. And I saw where they got the code from. It's the most brilliant thing I've ever seen to date with risk scoring.
So Dr. Sacheti, what do you do in your practice in New Jersey? Do you do something what Dr. Bansal do, or you do something what Dr.
This is what Dr. Bonsal's doing. See, I mean, it's two different products you're talking about, an ACO and the MSO. And the MSOs, they got they'll leave a lot of money on the table if they don't get these risk scores up. Whereas ACO, we can only get, you know, a 3% bump. But it's nice. It'd be nice to put in the ACO a long-term plan with a couple coders and slowly go through it. But the MSO, I mean, if Bonsal's got one down there, he knows exactly how getting these scores up, how important it is.
So I 100% agree with what you said. I think that's what we need to do. We don't need to go crazy at the moment with the MRA score in the ACO patients, but we do need to bump it up. So we do not at this level, but at some level where at least usual conditions which are missed are, so like you said, when they went through your chart, there were obviously conditions which were not mentioned. We generally don't think about it. I have, in my practice, have seen till I became aware of these coding, if a patient had hypertension, cardiomyopathy, CHF, angina, I would probably list just two conditions because I was getting paid for the same. And as long as I listed two conditions, I was fine. You know, I get paid the same. So never paid attention that I need to every time document all four conditions or address all four of them. But as we become aware of it, and that's the whole purpose that Subodh has organized these things, that even without a coder, we see some codes. As long as we just document what we see, obviously, I think we'll be fine. But we'll definitely in every ACO, we'll hire one or two coders and make sure that we get that 3% bump at least.
The other thing is when I went through this notebook, it was a great exercise in teaching me these new things I'd never thought of before. Just like Dr. Bounce, I never thought of these things. And it was it's, you know, like you're giving these seminars tonight to try to teach people. That was the best thing I've ever had, was figuring out what was right under my own nose and my own charts that I knew the patients, you know, like the back of my hand. I mean, it was a great education for me. And now this last quarter, you know, I'm going to try to get my ACO scores up. I've already gotten the MSO patients up. And then, by the way, MSO, you got to do it twice a year. You got to have the codes on there twice a year. So I'm about to make my second. They just handed me the notebook a couple days ago, and probably tomorrow afternoon, I'm going to go on the second half of the year and make sure I have all the codes in that notebook on their last note or their next note. I just go to the HPI and write a note to myself, please add this to the next note. And then once you build the problem list, like in your presentation tonight, it's there. It's work up front to build that problem list, and then it's there forever. And let me ask a question about to the coder. So she mentioned she switched hypertensive heart disease with chronic kidney disease and heart failure stage to 1 to 4. My question is, that's okay, but that's a very non-specific heart failure. Will we get more a higher risk score with a systolic or diastolic or New York heart failure 4, a much more specific heart failure than the next code was just a generalized heart failure?
Yeah, the score would be the same. The code that indicates hypertensive heart failure with CKD 1 through 4, the coding guidelines require you to document, in addition, the CHF. Now, if you find through your chart that you can get to a more specific type of CHF, then yes, document systolic diastolic combination, but the score would not change based on CHF unspecified or specified.
But then again, so you said hypertension, heart disease with heart failure. If it's systolic heart failure, since the heart attack, it should probably be systolic heart failure with ejection fraction of 35. Would be more specific, but would it be less score?
Actually,
it would be the same score.
Same
if the
score.
fraction is low, it becomes cardiomyopathy, which will a different condition, additional condition, which will add to MRA score. Absolutely.
Okay. And that's all.
Let me hear from what you do in New Jersey.
I had a lot of scores in my own chart that I never knew they were there. I mean, I had a
Yeah.
lot of diagnosis codes.
I will tell you that a lot of providers, the atherosclerosis or the lower extremities, they don't realize that when that report comes back, if it mentions any amount of plaque found in the artery, by coding guidelines, you're entitled to code for atherosclerosis, even if the report says minimal plaque.
Okay, so that's
Yeah.
exactly right. So what they do in the MSO, they go to the same cardiologist to read all the scans, and they get all these scans and pay for them up front, because if they see a little plaque in the legs, they can code it as atherosclerosis.
And there is a reason for it, because it's not just for coding. Because once you establish a vascular disease anywhere, your treatment changes. Your goal for cholesterol changes. You need to start them on aspirin if Subodh agrees, and you have to watch for other areas where there may be more atherosclerosis. They definitely have more incidence of coronary artery disease, people who have peripheral vascular disease, even if it's a small one. So it does make a difference. It's not just coding exercise. It does make a difference.
Yeah, I totally agree with you. The awareness of atherosclerosis is still pretty poor. Like with established guideline, with atherosclerosis anywhere in the body, your LDL has to be 70 or below. And, a lot of people don't get that kind of treatment. The reason is basically, first thing, we don't diagnose properly. Second thing is, once even we are not aggressive about LDL, but there's data now showing that decreasing LDL cholesterol improve life, prolong life, improve the quality of life. So finding atherosclerosis in the leg, if it's real, change the treatment, I think is good for the patient.
So what they're about to do is they just hired a ultrasound tech and just bought a machine, and they're about to ultrasound all of my MSO patients for free from head to toe.
Okay, so let me ask you.
I'm going to get reports, and if there's atherosclerosis of the aorta, the legs, peripheral vascular disease, do you see how you could come up with these codes?
So they can afford it because they don't have to answer to Medicare for doing those tests in the Advantage plan, because they're full risk. So Medicare is not for it. But in general practice, Subodh can guide you that you'll have to use some kind of a diagnosis. You have to suspect something to order it, because Medicare per se doesn't allow you to do testing based on screening, except for certain conditions. Like if somebody is a smoker, you could do a high-speed CAT scan, something like that. So, or if somebody is a smoker, you can do abdominal ultrasound for aortic aneurysm above age 65. But
Right.
for peripheral vascular disease, that kind of thing. So you just have to suspect, either you look at the pulses, there may be slightly weaker pulses, or if they're complaining of any other kind of pain, or if you suspect that he's got high risk and you suspect he may have peripheral vascular disease. So you have to have some kind of a diagnosis to order the test, because Medicare pays for it.
Right, but once again, their return on investment is they're at full risk. They're paying for it, and
no doubt about it. Yeah.
Mhm.
No doubt about it. What you're saying, return on investment is huge.
So let me get input from New Jersey. Vinod Bhai, tell us about what you're learning and what you're doing, or can you add anything in it?
No, I think what Raj was saying, it is very correct. Today, like one new patient came and he asked me, he said, Dr. Sancheri, can you order protein S and protein C and factor V Latin? And he was no disease on him. So I had to put a code, a personal history of coagulation defect in the family. Then only I was able to order a blood test for that patient. So I know we have to be very specific with diagnosis, and all CMS or all this private insurance want to be more specific for Advantage plan, so that they can justify that they have a lot more sicker patient in order for them to get more money from CMS for Advantage plan. What David is saying is all applicable to high-risk patient in order for CMS to give extra money to them. So as far as we put pertinent codes, 4 or 5 codes, 6 codes, then it's good enough. 7 codes, 8 codes. If you're diabetic, then you have to add a lot more in diabetes associated ulcer, diabetes associated peripheral vascular disease, diabetes associated nephropathy. So each disease has a pertinent codes which you had to put. We are forced to put certain codes in order for us to increase our MRA scoring for outpatient setting. So.
Right. Okay, go ahead. Sorry for interruption. I just want to clarify and get people involved in discussion and learning about it.
No, I'm good. That it's all a great discussion. Continue.
No, go ahead.
I just wanted to show you our process down here, how we identify the conditions, how we assist the providers in maintaining their problem list so that only accurate conditions are in there and available for use. And then how we, on a daily basis, go in the morning and make sure that all the conditions are there so the doctor is prepared to assess them that day.
Very good. So, do you have anything else to present?
Nope, that's it.
Okay. So, David, do you want to say something? Do you want to add something else?
No, I missed last week's session. Did we share the bazooka?
Now, I can put it out there for the handout. And
Yes.
actually, let me take that back, because as of Thursday, the bazooka is outdated. So it has to be revised.
But I think it's still a helpful tool. We can update it, but especially to see that some of the codes have no weight, like CAD, and then that the diabetes unspecified has a much lower weight.
Yeah, I just want to make sure, because Thursday the new ICD-10 codes come out, so the codes will change possibly.
So David, can you tell everybody, or Terry, what bazooka is? Is it a gun, or it is a pistol, or is something else?
David.
Sure. So, over the years, the payers were reluctant to share all of the details on the codes, for whatever reason. So, with Carrie and Dr. Bansal, we were able to research all of the
most common ICD-10 codes by disease. So if you break it down, it has diabetes, it has heart disease, it has kidney disease, and then it has like the top 10 codes that are weighted, and then it has the weights to the right. And then doctors are often, very surprised at the different weights by codes, and then they say, "Oh, I could have coded that. I didn't know that it had such an important weight." And it really kind of opens the eyes of the physician. I know a physician that reads it before bed a couple days a week just to remind them to diagnose these codes when relevant. But it happens to be the best document I've ever seen in the last 15 years because, like I said, the payers are reluctant to share all the details, and you can see exactly how Medicare scores each code.
So the Bazooka can be obtained from their ACO. Dr. Suchit, do you have Bazooka in your ACO?
No, we don't. We'll get it from David. David, will you be kind enough to send it to us, this Bazooka business?
Yes, sir, of course.
All right. Thank
So
you.
I think in our doctor's ACO, we distribute Bazooka to all our people, and basically we're trying to ask them to use it, and so it's this meeting might, and what Kerry is teaching her, that may bring the attention to them, then start using Bazooka. If we start using Bazooka in all practice in ACO, I'm sure we will improve the MRA score to the point where we can get 3% increment. So anything else anybody want to bring to the topic? I mean, to me, it's been a very great learning experience looking at Dr. Bunsel's way of practicing. It's impressive, really eye-opener. I wish I could have a record like that with everything together beautifully. So hopefully we will go towards that direction. Anybody want to say anything? So
No,
let
I
me-
just, I see that they're asking where to find the Bazooka. We'll give that to Daryl to put out as a handout?
So,
Or I don't know if you have them laminated for your providers?
Yes, we have laminated, we distributed, and no, we will send it to New Jersey too. David, let's make sure everybody who come to Kerry's talk here get Bazooka free.
Yes.
So just you request to Kerry, and Kerry will distribute to everybody. We will take care of that.
Okay.
Yes, sir.
So everyone, I want to thank you, Subodh. It was his brainchild. He always thinks about everyone, to include everyone, to get this teaching session going. Thank you very much, and thanks everyone. David, thank you. You've always been a great part. Vinod, thank you, and thank you everyone. Dr. Bond, your comments were very useful. Bye everyone.
No, you don't go yet. Let me tell you some few things. So the ACO members, Doctors ACO and Palm Beach ACO and New Jersey ACO member, the money is in the bank, is that right, from CMS. David, can you tell us the good news, things like that for Doctors ACO? We're going to distribute money on 10th of October. And there's going to be a virtual meeting as well as an in-person meeting in Athens. And then other ACO will probably distribute earlier than us. And what about you, Vinod Bhai? When are you going to distribute the money?
After October 15th.
Okay, very good. Awesome. So
Thank
the 10th of October, and it's going to be Saturday, we're going to send an invitation to us. And I think we will invite people to join that meeting too. And so thanks again, Raj. Thanks very much for sharing your record. I appreciate that.
So about the distribution, I think we should all thank David. You have no idea. He has been working since we got the numbers. Forget about the money, numbers, day and night. Honestly, last night I was with him at around 11 o'clock or 10 o'clock with 3 other people, Amanda and TJ, trying to sort out few things at New Jersey, trying to sort out doctors. What he does a deep dive. He's not superficial where you see one number and they may not be the complete numbers, and just based on that, because that's very easy work, then he can sit at home. What he does, he wants to be fair to every PCP. He goes deep dive, looks at every possible number that can affect other person's numbers. Because if the money is limited, so if Doctors ACO made 6.6 million, And if you change one person's number, others will be affected. So he wants to be very fair. He does an incredible deep dive. And that's why it takes a little more time than some of the ACOs who just distribute without caring. So he wants to make sure the people who put in their effort, whatever it is, it goes to the right person. And that's why it takes a little longer. So
No, I second that. I second that. I think so far in last 5 years, David able to convince every unhappy physician that why did they got more money or less money, and that's very impressive. So David, thank you very much. We appreciate your help, appreciate your numerology, appreciate your hard work.
Yes, sir. We're going to have a celebration very soon. The money's coming.
Very good. Thank you all. Appreciate it. And I was wondering we will continue this service till we start getting some results in the doctor's practice. So I'm going to send a request to Kerry, and we will meet again in 2 weeks.
Thank you.
Good night, everyone.
Thank you. Thank you. Bye.
Good night. Thank
Good
you.
night.